Hello people, so this is Dr. Muskaan this side with a new and a very interesting case today. You have heard about asthma, you have heard about COPD, but have you heard about ACOS? To my consciousness, what is ACOS? Oh my goodness, is it asthma COPD overlap syndrome? ऐसा भी कुछ होता है? हाँ होता है. Let me take you towards the journey of this case. There is 58-year-old female who presented with chief complaints of fever with chills and rigors with body ache and shortness of breath. The female is hypertensive and is on irregular medication with newly diagnosed type 2 diabetes mellitus. On examination, there was bilateral pedal edema. Fever was 101.2 degree Fahrenheit. Decreased urine output was there. Now, on CBC, that is blood picture, we find that hemoglobin was less. It was 8.7 gram per dl and the platelet counts was only 63,000. On USG, we have found that there was mild pleural effusion. There was electrolyte balance which was found in KFT, that was hypernatremia and hypokalemia, my dear friends. Yes, hypokalemia. And you know that hypokalemia is dangerous. Now, to restore the platelet count, the SDP was transfused in the patient. ABG shows decreased PO2 and increased PCO2, which takes us to the diagnosis of type 2 respiratory failure. And in ABG, lactic acid was increased, which was telling us metabolic acidosis, as we know that lactic acid increase in lactic acid is one of the cause of HAGMA, that is high anion gap metabolic acidosis. In LFT, we have seen that SGOT, SGPT was increased. In KFT, we have seen that urea and creatinine was increased. So till now, the history which I have told you, we have made the diagnosis of dengue fever because of decreased platelet counts, mild pleural effusion on USG, presence of the features of dengue such as fever, chills, rigors, body ache, and some investigations which I have shown you right now in LFT and KFT, which is deranged. The second diagnosis which is made is type 2 diabetes mellitus, which was newly diagnosed because of increased RBS of the patient, and we know that there was comorbidity hypertension and the female was on irregular medication, and from ABG we have diagnosed it is type 2 respiratory failure. Till now, the history I have told you, we have 4 diagnoses. 4 points in our diagnosis. One is your dengue fever, second is your hypertension, third is your type 2 diabetes mellitus, and fourth is type 2 respiratory failure. Further, on chest x-ray, the finding was bottle shaped heart. You were thinking about COPD? Bottle shaped heart. Then on HRCT, the findings were emphysematous changes in the bilateral upper lobes with pleural thickening along with effusion in the posterobasal segment of right lower lobe of the lung. So, bronchoscopy was planned for this patient for further investigations, and the findings were extreme tracheobronchitis with cobblestone lesions, high priority of fungal tracheobronchitis. It was very different findings which I have seen, and from all these things we have made the diagnosis of COPD. Why COPD? Because T2RF, that is type 2 respiratory failure, was seen in ABG. Your chest x-ray findings were taking us to the diagnosis of COPD. Shortness of breath, HRCT. So after all this stuff, when I auscultated the patient, I found there was bilateral V's and the use of the accessory muscles of the neck, and I was thinking this is found in asthma. Your V's, your using of the accessory muscles of the neck. So hence, till now I came to know that in this patient there is ACOS. ACOS is known as asthma COPD overlap syndrome. Basically, asthma is something in which there is chronic airway inflammation. It is defined by the history of respiratory illness, having shortness of breath, wheeze, and chest tightness. In COPD, we find that there is persistent airflow limitation, which is progressive and associated with chronic inflammatory responses in airways. Now, in this patient, there is an overlap. On chest auscultation findings, we found that there was asthma such as wheeze, use of the accessory muscles, there was airflow limitation, but On chest x-ray findings, we have found that bottle shaped heart and some basic findings of COPD patient like T2RF, and hence it is a diagnosis might be ACOS, that is asthma COPD overlap syndrome. So my dear friends, I really enjoyed learning on this case, but some of the questions which came in my mind, that first question was, I need to know the gold guidelines for COPD. So my mind was thinking why we cannot do PFT in this patient and get the gold guidelines. Then I thought, oh my goodness, this patient is in ICU. How can a patient blow and get the PFT done, and we can get the FVC FEV1 ratio, and we can see that 0.7 से कम है तो obstruction है, ज़्यादा है तो restriction है. So my mind was towards कि फिर उसकी जगह क्या होता होगा पीएफटी की जगह, अगर हम गोल्ड गाइडलाइंस नहीं देख सकते. तो द आंसर वाज द क्लिनिकल फाइंडिंग्स, योर चेस्ट एक्सरे, द ब्रोंकोस्कोपी, योर HRCT विल हेल्प टू मेक द डायग्नोसिस. So the second question which came in my mind was why this patient is in ICU and not in ward, because I have seen COPD patients in ward also. So the answer for my question was the patient needs proper and close monitoring because there was type 2 respiratory failure, and the other indications was bronchoscopy which was planned for this patient. The patient was on ventilator. So this was the answer. So why I told you this question, because whenever we are studying the case in ICU, the question which comes in our mind is why the patient is in ICU and not in ward. And when you will think in this line, you will come to know many things, because one question has many answers, and it will really help you to work in critical care team. So that's all. I really enjoyed sharing this case with you. I hope you also enjoyed listening to it, and maybe you also got some good points from my side. Thank you. Dr. Muskaan is signing off now.